my best plan for TKR Analgesia. We know there are many recent advances in the field of anesthesia. In my previous institute, we were talking about the indications of TKR. Unfortunately, even in India, people tend to go for TKR only when they have some inability to handle their own toilet or something. And you can see this absolutely crippled individual who is not able to, you can see severity of varus, valgus, lot of swollen combination predominantly. It's a very, very difficult joint. And I think things have changed for good. Of course, this was in Ganga where I have worked. And that time the surgery was done and there was a boom. But I think the indications are changing nowadays, and that is why we are here. And nowadays, even if people are not able to play golf, they will get themselves operated for TKR. So standard of living and all these factors are into account. So there are changing indications. We are now in the era of even the unipolar, unicondylar TKR as well. So there are no conflicts of interest. The videos I have taken due permission. These are my own patients. When it comes to TKR, the regional anesthesia strategy, what I'll be discussing little bit upon the anatomy, the challenges with block, postoperative analgesia plan, literature review, prospect guideline, and ERAS. So this is a very interesting read for lower extremity, dermatome, myotome, osteotome. So what is the dermatomal supply of knee? If we want to give spinal with tourniquet, how much level? This is like a basic fellow PG class. We ask all these basics. So good idea to have working knowledge, though it is predominantly femoral, but as we can see, there is some component obturator and to some extent sciatic in the posterior area as well. Muscular supply, that also, though it's not a muscle cutting surgery, but we tend to split a lot of muscle which causes soreness and thereby pain. And at the end of 3 and 4 hours, we are mobilizing them, so it increases the soreness. So sometimes, we have to address these edema and other areas as well. So the purpose of knowing cadaveric anatomy is that we can be more site specific. So this is the femoral nerve, and what is our area of interest is the saphenous nerve, how, and the nerve to vastus medialis, which is again, you can see here. Even some of the cutaneous innervations of nerve to vastus lateralis and intermedialis also sometimes tend to help cover some aspects of knee, but it is predominantly nerve to vastus medialis and the saphenous nerve when it comes to femoral. So we tend to address those issues on priority. Nerve to vastus medialis is very important, and you can see how it divides, what is its course. People tend to block it nowadays. We tend to block it little more proximal before it divides, and therefore the quality of analgesia improves. Now, obturator nerve also has got anterior and posterior division, and you can see the posterior division here is predominantly for hip joint, whereas the anterior division comes down and helps on the medial side. You can see posterior division and the anterior division. So that's the anterior division, and it is supplying the hip joint, and the posterior division, it is traveling, it is supplying the obturator externus, the adductor magnus coming through adductor hiatus, articular twigs to knee joint. So if we want to block and help with TKR, it's the posterior division. Okay. There is also some component of posterior knee pain, and people are talking about posterior capsular infiltration. So here is a good plexus which is formed predominantly by the sciatic as well as from the articular branches of obturator. And so this helps us to understand. Previously we thought it's a single nerve or something, but we are now here dealing with three plexuses. One is peripatellar plexus, second is subsartorial plexus, and third is a popliteal plexus. So peripatellar plexus, as I have mentioned, there are several branches which we may not be able to address. So local infiltration analgesia is a good choice. Sometimes if LIA is not being used, then genicular nerve block people have tried along with other adductor canal plus IPAC. But since our surgeons, most of us are using LIA, so probably genicular nerve may not be required. Subsartorial plexus, most of us utilize this technique where we address the adductor canal. and the popliteal plexus, which is like posterior knee infiltration. And nowadays we have moved to IPAC and things like that. So what is the ERA? ERA is a food court or cafeteria approach, and these are some of the anesthesia factors which I could think of. So even if our family members or even the friends are going for a party or something, none of us will have the same choices. So there is a menu card. So nowadays, how will you choose which block is good for my patient? So I'm just highlighting here the anesthesia factors. Of course, there are institutional factors and surgeons and a surgery factor, patient factor. But more important to us are the anesthesia factors. So it depends on skill set, depends on infrastructure, depends on availability, budget, availability of help, attitude, motivation, passion. And some I've seen, I mean, it's okay. We have given some block, we have done block for block's sake. But there are some group of anesthetists which I believe are passionate and they want to do a case, each case as a signature case. And then there is a role of anesthesia excellence. And if we are motivated and passionate and we have RA attitude, I think it is possible with in the era of ultrasound. So blocks for surgical anesthesia, there is definitely central neuroaxial, lumbosacral plexus, or a sciaticofemoral. We have tried all of them, and sometimes in high risk knee surgery, which I'm not going to address today, it is lumbosacral or sciaticofemoral, and we can get away with that. So, what are the block options available for analgesia? So, there are multiple options when it comes to saphenous nerve. So, these are the subsartorial block. We have femoral block. Adductor canal has, we have seen from 2010 to, it has evolved like anything. There is a dual subsartorial modified 4 in 1, even the visa plane block by from Connecticut by Dr. Sinha. Then we have, popliteal plexus, which is being addressed by IPAC, distal adductor canal, obturator selective, and then we have site-specific blocks like LIA or genicular. So what is the strategy? It is loco-regional, opioid sparing, multimodal, site-specific, procedure-specific, motor sparing, analgesia. So the buzzword I'm going to highlight whenever possible, do local infiltration, encourage local infiltration. I have done a blog, Tata local deu naka. That probably is not a good idea because it's a rich nerve supply. And peripatellar, we need to cover that as well. So whenever possible, try to do a block. Regional strategies are really good. Whenever possible, opioid sparing. Opioid has its own set of adverse event. It is multimodal essentially. We are in the era of preemptive, preventive analgesia. It is site specific. If one limb is getting operated, why should I block both limbs? Procedure specific. If it is a unicondylar fracture, my strategy is different. If it is ACL, MCL, PCL, my strategy is different. Redo, my strategy is different. So procedure specific and motor sparing. We had a patient recently got operated. She has four sons and they were also stressed out. And at the end of surgery, I'll be showing you a few videos. When we are mobilized on the day of surgery, there was so much of positive reinforcement. And they said surgery हो गया बस कुछ नहीं सब डॉक्टर अच्छे हैं हॉस्पिटल अच्छा है. ERAS is a evidence-based statement now. So motor sparing analgesia is the thing which we wish to achieve. I have worked in my previous institutes in corporate Mumbai, Hinduja, Leelavati, and those old days we were very much banking on morphine, PCAs, IV opioids. Even in resource limited settings in freelancing, people do use a lot of Fortwin and patches, opioid patches. But that is not a very, I would say, evidence-based strategy. Of course, when we have something is better than nothing, so I would not criticize it. If I am in that position, probably I would have opted for the same. But if given a choice and if possibilities are there, we should move towards site specific. So we have moved from systemic to central neuroaxial to more and more peripheral nerve and LIA. And today is the era of liposomal bupivacaine. So my plan here is usually this is routine plan. We have different set of surgeons. So I do modify my strategy depending on the patient, the institutional protocols, and the surgeon. It is, of course, the surgeon which encourages us. I share a lot of evidence with them. So this is our routine plan. I usually give a spinal with 20 mics of clonidine. 20 mics will not cause much of hypotension. So we get a favorable hemodynamics of around So it is 1.5 mark of a 1cc syringe. It produces pulse rate around 60 and BP around 100, which is very favorable. It reduces, if we use more of clonidine, it causes hypotension, need for fluid. Then we end up giving epipress, which causes even tachycardia, oozing, need for transfusion. So we have published from Ganga one paper on clonidine, where if we use 20 mics, it has been found to reduce the rate of urinary catheterization and blood transfusion for arthroplasty procedures, TKR and THR. Of course, it's a under tourniquet surgery, but favorable hemodynamics is a welcome step. Then once this block is done, immediately we do IPAC with 20 to 25 ml of 0.2% ropivacaine with ultrasound. We add 8 milligram of dexamethasone as we do not have liposomal bupivacaine. Then LIA by surgeon at the end of surgery, they do infiltrate. Sometimes they say give us less volume, 30-40 ml is good enough. So we give them 1 or 2 ampule of 0.2 ropivacaine. They tend to add ketorolac, adrenaline, usually to make it 5 microgram per ml. With or without steroid, antibiotic, opioid, clonidine, we all know how our surgeons will have their own protocol. And post-op, we tend to give an adductor canal block, which I will be demonstrating, and we use PNS to identify nerve vastus medialis, and we place a adductor canal catheter. We keep them on intermittent top. Now, in my last almost 7 years of practice, none of the spinal I have done nowadays with landmark. It is always fish with ultrasound. So it's a crisscross method. We just identify the posterior complex and the anterior complex. So this is the spine, which is creating the acoustic shadow. And when we just slide it up in a transverse approach, we tend to see the posterior complex. Yeah. So this is the posterior complex, and that's the anterior complex. So posterior complex is nothing but the posterior dura and ligamentum flavum, and anterior complex is anterior dura and posterior longitudinal ligament. So you can see this posterior complex with ultrasound. So if ultrasound beam traveling in straight line can hit dura, why not my needle if I follow the same straight path? So I mean, as a community, why not we can be precise and accurate with our approaches? If it is my surgery, I would always prefer single prick. And if it is somebody else's surgery, how can we opt for that? So my approach is, I think, if this is the quality care, we must take an effort to mobilize the machine. And we have done completed one study. Our success rate is with needle redirection. When we have compared both groups, it is we have in our limited study it was 100% success with 30 patients where we have included and 30 in other group. So what I mean to say is once it is nicely seen, the target is in front, maybe little bit of needling is, but we do not have to take a second puncture. So also when we do not see any complex anterior or posterior complex, I inform the surgeon and the patient beforehand that I'm just going to try once or twice. It could be because of artifact, I'm not able to see anything. And if success is good, I'll try once or twice. If not, I'll convert straightforward to GA. So that's my routine approach, and it has helped so many patients. Now we are talking about IPAC after spinal. Immediately we keep ourselves scrubbed and we do the IPAC. It is an infiltration block between the popliteal artery and the capsule of knee. So this is how we place the probe for IPAC. It is just above the upper edge of the patella. And what we see here are the vessels. You tend to see the vessels, and we deposit the drug between the capsule of knee here in this direction. So between the vessel and the capsule of knee. So it's around 20 ml of local anesthetic. So this was all Chittaranjan Ranawat who started with the LIA technique, and he has his own big, they call mixture. And multimodal analgesia is the strategy. So in our all our patients, definitely my preference is for magnesium sulfate, pregabalins in selected group of patients. In elderly, they tend to get excessively sedated or dosed off, so we tend to avoid. Pre-incision ketamine is a very good robust evidence to utilize it in all patients. As far as pain chronicization, local infiltration analgesia and subanesthetic dose of ketamine can prevent pain chronicization. And IV dexamethasone, I'll be discussing on the prospect guideline, paracetamol, NSAIDs, and LIA by surgeon. So it's a iatrogenic fracture, and surgeon tends to deposit the local infiltration. And some of our surgeons have done the cadaveric dissection studies, how to do local infiltration. Otherwise, it is just a spraying of holy water. It doesn't work. But some dedicated surgeons, those who are practicing in a methodical way, they are with good results. So where we should be depositing first quarter, second quarter, third quarter, and fourth quarter. So it's around the posterior capsule, medial periosteum, lateral periosteum, soft tissues, and skin. Any LIA will definitely act for 7 to 8 hours, not more than that. So there is a role of block, and this is a good article by Bala sir, Dr. Karthik, and they talk about dual subsartorial block, where first injection we identify the apex of femoral triangle and 2 centimeter proximal to the apex of femoral triangle. This is the first injection. It is also known as distal femoral triangle block. And the second injection is 2 centimeter distal from the apex of femoral triangle. So we identify the femoral triangle 2 centimeter above to 2 centimeter below. This is how injection are being described. Now, how I utilize it in my practice, I tend to utilize the first injection. But second injection, I think we have succeeded in convincing our surgeons that we are safe and we take good care of aseptic precautions, and therefore they have allowed us to do LIA. So why to depend on something like proximal adductor canal and we expect the drug to sip through the adductor canal and reach the popliteal plexus? So that siphon effect and all that. I think I believe in addressing this problem, this challenge upfront. So if I want to block popliteal plexus, I would like to deposit then and there itself. So IPAC is the strategy, but definitely nerve to vastus medialis is very nicely seen with this first injection site, which is the distal femoral triangle. So I think if in some patients where surgeons are not allowing us to do IPAC, I think dual subsartorial is still one of the very good strategies. So this is the apex of femoral triangle, and when we how the femoral triangle ends and the adductor canal starts, there is this sign of three, and you can see this sign of three. So this is the sign of three. Can you appreciate that? Yeah. So above is the sartorius muscle, and yeah, so below is the adductor longus, and this is the sign of three. This is the medial side, and that side is the lateral side. So here is the femoral artery and vessels. So this is the start of adductor canal. So 2 centimeter above and 2 centimeter below is the dual subsartorial which has been described. So distal femoral triangle, I'm just drawn here. So that's the apex is the line. 2 centimeter proximal is the distal femoral triangle where the probe you can see. Then there is an arrow. This is the mid thigh approach, and lower down is the distal adductor canal block. So this whole length is the adductor canal, which is around 8 to 10 centimeter, and you can scan it. So the start point, so 2 centimeter up, 2 centimeter below for dual subsartorial. Sometimes the dressing is still here till mid thigh. So therefore we have to follow this dual subsartorial mode. All right. So this is the place for my first injection, which is a distal femoral triangle region. So this is again the sign of three, and we move the probe cephalad. You can see it has become something like a dolphin beak now. The sartorius has become dolphin beak, and we have moved in the lateral area. Here you can appreciate the saphenous nerve and the nerve to vastus medialis. There can be sometimes vasofemoral fascia in between two. So we have to do dedicated 2 injections to block this. Now to vastus medialis, you can use PNS as well. Mid thigh approach, if we drag the probe little downward, the femoral artery comes at 6 o'clock position here. So this is the 6 o'clock position, and on the other side, where from lateral to medial, my needle will come. This is vasoadductive membrane and vastus medialis muscle. So once this first injection is done, I drag the probe little downward, and this is the conventional mid thigh approach. And I deposit, I open up vasoadductive membrane and turn the probe little obliquely. So 6 o'clock position here, we have to be very careful with the arteries. And I tend to put a catheter. So how I put the catheter? So this white thing is the sartorius muscle. So first I identify the femoral artery somewhere lower down where it is at 6 o'clock position. The artery is at 6 o'clock position to sartorius. And I tend to rotate the probe in such a way that artery continues to be circular. So I'm not going to get a long axis scan of an artery. So in this picture, The artery is still circular, and this is little oblique approach. Now I place the catheter as I have directed through that pen. So now the catheter, instead of lateral to medial, it stays in the long axis of sartorius. So that's the idea. And there are how to insert the catheter. So we are doing an in-plane technique. Oblique approach also has been described. There are different catheter over needle, needle over catheter. So we tend to use needle over catheter. And that is why our catheters do have some para catheter leak. And that is beneficial to cover that nerve to vastus medialis. So I tend to put that through the vasoadaptive membrane. I open up and the catheter lies through that and it goes near the saphenous nerve. With paracatheter leak little bit, it also tends to cover very in a nice way nerve to vastus medialis, because at mid thigh the nerve to vastus medialis is little bit lateral to the artery. So we do subcutaneous tunneling and there is reduced incidence of infection as well. So this is with Xavier Capdevila, nice article, and we fix it, label it. And there is a little discussion about program intermittent bolus and continuous infusion. Previously we were on continuous infusion, but I think if you wish to use intermittent boluses, I think 8 to 10 ml of 0.2 percentage ropivacaine 6 or 8 hourly is a good idea. And whosoever is doing a single shot block, I would like to see their patients 24 hours after surgery. And believe me, TKR is the most painful surgery. And usually after 24 hours, they are in too much of pain. So as acute pain physician, we are responsible for first 72 hours of pain relief. And then there are instrumented spines and back where we cannot put epidural. We have even in some old patients where there was emphasis on bilateral TKR, again is a challenge. Here we have placed bilateral catheters. What has happened is right-sided vas score was more than the left because of the knee anatomy to start with. So we could address it differently and we could give intermittent bolus one here 10 ml, 5 ml. So we can fine tune our, even in obese patients, operated spine and all that. So what are the prospect recommendations? So prospects, they look at a lot of evidence, Cochrane data available. So NSAID and paracetamol are recommended. Single shot adductor canal block with periarticular LIA is recommended. We do not have too much articles to support that catheter and other things. And, of course, these are the principles and guidelines, and how it suits your patient, you can fine tune it. But yes, this is a prospect recommendation where we have single shot block with LIA, single shot intravenous dexamethasone, intrathecal morphine if adductor canal block or LIA is not possible because of anything, and opioids are only for rescue. Now, prospects has come up with interventions which are not recommended, and these are gabapentinoids in elderly patients because they get dosed off. Ketamine has a conflicting evidence. Dexmedetomidine, big no. Epidural potential adverse effect with rapid recovery, so big no. Femoral nerve block, negative impact, and sciatic nerve block also is with negative impact. So, of course, but some patients, I must say, what are the indications for epidural in my practice? So, I would say definitely in some patients like operated spine, or in some patients where we have bilateral surgeries. Operated spine epidural probably is not possible. There is only 50% chance that it may act. Then there are patients who are high risk where we want to do low dose spinal with epidural. So epidural is used for surgical anesthesia, where we can get away with very low dose of spinal without causing hemodynamic instability. Femoral block we do utilize when pain is the priority and surgeons are not planning to mobilize the patient and patient have pre-op VAS score on a very higher side. I think epidural or sometimes with femoral combination we tend to use, and if we have not placed a catheter, then next day we repeat the block. So call them to recovery. Then the sciatic nerve block is not a preferred block. What is the incidence of local anesthesia systemic toxicity? Recent articles suggest, this is an older article, but 2021 and 22, if you read RAPM, they talk about intermittent boluses, and we have to be very careful. So as I think 250, 300, 400 mg of ropivacaine, better to use ropivacaine than bupivacaine. So it has its advantage, and we have to be very careful when surgeons are doing LIA, what concentration they are using, and we should be putting that in our notes as well, so that we have a total awareness as how much local anesthetic has gone in, right from spinal and blocks and catheters and LIA. So some focus is essential nowadays for regional anesthetists. Quick eyeballing views is a good idea, and usually fluid deficit or fluid challenges is one of the important thing. Sometimes with more tourniquet time, extensive surgeries, looking at IVC, looking at B lines, all this. Now the most common cause of death in arthroplasty is pneumonia and bedridden patients. So incentive spirometry and all those things, good antibiotic prophylaxis, and make them sit and doing. And all our patients we check for bladder, and with Nelaton catheter we remove the urine on table itself, and we do not catheterize our patient. So ERAS talks about good night's sleep, able to pass urine, eat, drink, physiotherapy, no breakthrough pain, less PONV. I think with adductor canal and LIA, we can able to achieve that. The four indicators for postoperative assessment is range of motion, tuck test, which is time up to go test, ambulation distances, quadricep muscle strength. So this was our patient where we have utilized this. I'll show you. So surgery got over at 12 p.m. and this is at 4:30 p.m. You can see there is no quadricep weakness, there is no foot drop. So we have done an adductor canal block and a LIA along with IPAC. So you can see I'm checking for the quadricep weakness. So he's able to extend his knee also. Yeah. So there is no quadricep weakness at the end of 4 hours of surgery. So no foot drop. If we use too much of drug in IPAC, sometimes it can cause foot drop. So we have to be careful depending on the size of patient. So no foot drop, no quadricep weakness. So IPAC plus adductor canal block has worked. We have placed a catheter. The catheter was, so this was our patient to start with initially. You can see. So it is varus deformity. All our blocks are meant for varus deformity because surgery is done with medial parapatellar orthotomy. If it is valgus, it is more of a sciatic component. So this bow knee is better treated. So this was how. So he was an ex-military man, very much motivated, undergone all the prehabilitation exercises, including nowadays there is talk about aqua aerobics, so walking in swimming pool, and 1 month of physiotherapy before surgery. So he was extremely motivated, and we can see that at the end of 4 hours after IPAC and LIA plus adductor canal, he is able to move, and he he reads many inspiring books as well. So you can see even as he was aware that I'm going to show this video to all of my anesthesia colleagues who believe in anesthesia excellence. He said, let me try this also. You can show them. And I asked him, do you have pain? He said, what pain? So that was his motivation. So thank you very much for patient listening. Hopefully I've shared some important points which probably you found interesting. Thank you.